Chapter 28, soft tissue. And I'm going to go right into it. Introduction. Skin is the body's first line of defense and is susceptible to various types of injuries. Soft tissue injury may result in exposure of deep structures. Dressings and bandages are applied to control bleeding. They prevent further contamination and they protect the wound from further damage. Injuries include blunt injury. Energy exchange between the patient and an object is more than the tissues can tolerate. The skin is still intact. The damage is underneath. Penetrating injury, object breaks through the skin and enters the body. Once the object breaks the skin, the possibility for external bleeding exists and the possibility for infection also exists. Burns may also result in soft tissue injuries. Hemorrhage or infection may cause death. Skin structure and function. So anatomy and physiology review. Skin structure and function. The skin varies in thickness. There are two principal layers, the epidermis and the dermis. The epidermis is the top layer, dermis is the middle layer, and then you have the subcutaneous tissue below. Orifices in the body are lined with mucous membranes. Skin serves many functions. So it picks up changes in the environment related to the brain. It keeps water in, it regulates body temperature. Right? And it's a very important sense organ in the body. And of course, it prevents the microorganisms or harmful organisms from entering the body. Skin tension lines. Skin is arranged to provide tension. Tension lines are patterns of tightness. Static tension develops over areas that have limited movement. Dynamic tension is found in areas over muscle. Open injuries to dynamic tension lines interfere with healing. So wounds over the muscles, because movement occurs there. When the movement occurs, it can pull the edges of the wound apart, and that can affect the healing. And that's really why it's important that some wounds require suturing. One of the reasons. Pathophysiology of closed and open injuries. Closed injuries, contusion or bruise. Injury that causes bleeding beneath the skin but does not break the skin. And a contusion can be an ecchymosis or it can be a hematoma. Ecchymosis is a small blood vessel. A hematoma is a large blood vessel. So ecchymosis, blue or black discoloration, and it's more, blue or black discoloration, small vessels. Hematoma is a pool of blood that has collected within damaged tissue or in a body cavity. Crushing injury occurs when substantial force is applied to an area of the body. Closed injuries, crush syndrome. Tissue necrosis develops and results in release of harmful products into the bloodstream when the limb is freed from entrapment. So if a limb is trapped for 4 hours or more, the tissue can break down and die, and this results in crush syndrome. The mechanism cannot just be released because it's going to release all of those toxins into the bloodstream, which can cause serious complications for the patient. Swelling that occurs whenever tissues are injured results in a form of compression. Compartment syndrome is characterized by pain that is out of proportion to the injury. So compartment syndrome is a fracture that occurs over 6. So there's a fracture and there is bleeding occurring over 6 to 12 hours in the fascia compartment, which is a membrane around the muscle, and it creates compression on the fracture. That's compartment syndrome. Open injuries. Hold on, let me backtrack a bit. Yeah. Open injuries. Open injuries can result in contamination. So the patient is going to be at risk for infection, but in a pre-hospital setting, your primary responsibility is to control bleeding, secondary infection. Abrasion, caused by friction when a body part rubs or scrapes across a rough or hard surface. Laceration, smooth or jagged, or it can be a clean incision, cut caused by a sharp object or a blunt force that tears the tissues or tissue. Avulsion, injury that separates various layers of soft tissue so that they become either completely detached or hang as a flap. Amputation completely avulse body part. Animal bites, pathophysiology and pathophysiology of closed and open injuries with continuing. Animal bites. Consider all animal bites as contaminated and potentially infected wounds. May require antibiotics, tetanus prophylaxis, and suturing. Regard a human bite that has penetrated the skin as a serious injury. Penetrating wound injury resulting from a sharp pointed object. It can be accidental or it can be intentional. An open wound in the abdominal cavity may expose internal organs. Open neck injury can be life-threatening. Open wounds caused by crushing injuries may involve damaged internal organs, or broken bones. Blast injuries may also often result in multiple penetrating injuries. Pathophysiology of wound healing. Infection. Staphylococcus or Streptococcus bacteria account for most bacterial skin infection. Shows visible clues. So they can develop infection from these bacteria, and this can interfere with wound healing. And it's usually when the area is not kept clean or sterile. Gangrene, dead tissue, caused when blood supply to tissues is interrupted or stopped. Can be caused by other diseases, can become necrotic and result in sepsis. And they can develop tetanus, which is caused by an infection with a anaerobic bacterium. So they may require a tetanus shot. So tetanus caused by infection with an anaerobic bacterium, Clostridium tetani, causes the body to produce a potent toxin that results in painful muscle contractions that can be so severe that they can cause fractures. Necrotizing fasciitis. Fasciitis is inflammation of the fascia. Most serious form of this condition is called necrotizing fasciitis. It involves the death of tissue from bacterial infection. Now, assessment of closed and open injuries. A physician should always evaluate certain wounds. Assessing closed injuries is much more difficult than assessing open injuries. Scene size up. Dress appropriately. Maintain a high index of suspicion for internal injuries, and this will be based on the mechanism of injury. Initiate your primary survey. Rapidly determine whether threats to life are present using the XABCDE mnemonic. Control any visible substantial bleeding using appropriate methods. Perform manual immobilization of the spine if necessary. Check for responsiveness using the AVPU scale. Assess breathing and circulatory status. After you have completed your primary survey and you have addressed live threats, you should know your patient's GCS, should know if it's a load and go patient or stay and play, should know if your patient requires a rapid scan or focus. Next phase is your history taking. Gather information to determine how the patient was injured. Make every attempt to obtain a sample history. Using the OPQRST mnemonic may provide some background on isolated extremity injuries. So the OPQRST provide information on the presenting injury or problem. A higher priority should be given to patients taking warfarin or other anticoagulants. And that makes a lot of sense because these patients would be at risk of bleeding profusely. Secondary assessment. Performed to reveal injuries or medical conditions that may have been missed during the primary survey. Reassess the vital signs to identify how quickly a patient's condition is changing. Soft tissue injuries, even without a significant MOI, can cause shock. Use monitoring devices to quantify the patient's oxygenation and circulation or circulatory status. So monitor the pulse ox, get the patient on capnography, pay attention to your pulse pressure, pay attention to your mean arterial pressure, especially if you're giving the patient fluids. Make sure you put the patient on a cardiac monitor. You might want to obtain a 12-lead ECG depending on the type of injury that's present. Reassessment. Reassessment of the patient condition should be made en route to the hospital. Reassess airway, breathing, and circulation. Describe the MOI, the position in which you found the patient when you arrive on scene, and estimate the amount of blood loss. Provide an accurate account of treatment. So whatever treatment you have provided, make sure it's clear and detailed in your report. Emergency medical care. Emergency medical care. Closed injuries. Extensive closed injuries could result in hypovolemic shock and can be life-threatening. Treat a closed soft tissue injury by using Rice's rest, ice compress, elevation, splint. If you're using ice in the pre-hospital setting, shouldn't be longer than 6 hours. After that, then heat therapy might be more beneficial. Extremities that are painful, swollen, or deformed should be splinted. If the patient shows signs of shock, place the patient supine, initiate IV therapy, and it's going to be the largest IV catheter that can fit, especially if you suspect shock. And the fluid resuscitation will be based on protocol. Give high flow oxygen and provide prompt transport to the most appropriate facility. Open injuries. Appropriately treat open soft tissue injuries to minimize common complications. Take standard precautions and first address life-threatening bleeding or exsanguinating hemorrhage. Assess the severity of the wound to control bleeding from open injuries. Use direct even pressure dressings or splints, or use a commercial tourniquet or improvised tourniquet once your protocol allows and it is required. Chemical burn. Hold on, I'm hearing feedback. Okay, it's gone. Chemical burns and contamination should be flushed to remove remaining chemicals. And you're looking at 15 to 20 minutes of irrigating these areas with water. After the wound is irrigated, apply a dressing over the site. Neatly wrap and bandage over the dressing. Dressing and bandaging. Used to cover wounds, control bleeding, and limit motion. Dressing directly covers a wound and control bleedings. And the primary function for that is to control bleeding, to protect the wound from further damage, and to reduce the risk of infection and contamination. Types of dressing, you have various types. Universal dressing, conventional 4x4, 4x8, gauze pads, assorted small adhesive type dressings, soft, self-adherent roller dressings. Emergency medical care continued. Bandages, keep dressings in place. Use soft roller bandages, rolls of gauze, triangular bandages, adhesive tape. Complications of improperly applied dressings. Hemodynamic complications include the possibility for continued bleeding. So if it's not properly applied, bleeding may still occur. Can result in additional tissue damage or even loss of a limb. So if it's too tight, it can have a tourniquet effect on the area, and that can damage nerves and blood vessels long term. Management of specific wounds now. Avulsion. Replace the avulse flap in its original position. If an avulsion is complete, wrap the separated tissue in sterile gauze and take it to the ED. For an amputation, if an amputation is present, if an amputation involves a large area of the muscle mass, apply a tourniquet and treat the patient for hypovolemic shock. So with an amputation, you can consider the use of a tourniquet. With a crush injury, you should definitely be thinking about the use of a tourniquet. And for some injuries where major arteries are bleeding, then you may have to apply a tourniquet as well. With partial amputations, immobilize the part with bulky compression dressing and a splint to prevent further injury. With bites, do not enter the scene until the animal is secured. Promptly control all bleeding and apply a dry, sterile dressing. Immobilize the area with a splint or bandage. Provide transport to the ED for surgical cleansing of the wound and antibiotic therapy. Penetrating wounds. Entrance wound and exit wounds are difficult to distinguish. Count the number of wounds. Patient care is the priority. The amount of damage from a gunshot wound is directly related to the size, shape, and speed of the bullet. And remember, the speed will greatly increase the force. Abdominal wounds. If internal organs are protruding through an open wound, do not touch or move them. If the patient's legs and knees are uninjured, flex them to relieve pressure on the abdomen. For an impaled object, if the object is very long, cut off the exposed portion first, securing it to minimize motion. Open neck wounds, cover the wound with an occlusive dressing, apply manual pressure, but do not compress. And we don't want to go circumferential around the neck. With impaled objects in the mouth or neck, the only time we will consider to remove these objects is if it compromises the airway. The object is impaled in the chest, the only time we will consider removing it is if it's in a position where we need to put our hands to the CPR. With impaled objects in the abdomen, there is no circumstance for which we would remove that. It's outside the scope of practice. Burns occur when the body or body part receives more thermal, electrical, or chemical energy or radiation than it can absorb without injury. Pathophysiology can also be systemic injuries. Damaged cells release vasoactive substances. Fluid shifting from the intravascular space into the extravascular space causes edema. So third spacing can develop. Hypovolemia causes a decrease in cardiac output, resulting in hypotension or burn shock. As the burn destroys skin, a tough leathery substance known as eschar tissue is produced. Patient may require an escharotomy because there's no blood flow in that area. It has to be removed. And if it remains, it will affect other areas that have blood supply. Hypovolemic shock occurs because of two types of injuries: fluid loss across damaged skin and a series of volume shifts within the rest of the body. Depending on the nature of the burn, coagulation disorders may cause the patient's blood to clot more easily, resulting in an emboli, or it can fail to clot, causing excessive bleeding. Now, complications of the burn. Patient is going to be at a very high risk for infection, hypothermia, hypovolemia, and shock. Burn patients die immediately after the burn as a result of airway problems. They die later on because of infection. So if there's airway compromise after the burn, they can die pretty quickly. After the burn, if it's days or weeks after, then it would be associated with infection and fluid deficit. Complete airway obstruction is a complication. Compromised breathing compartment syndrome can also occur. Now, burn zones. Skin nearest the heat source suffers the most profound cellular changes. So, pathologic progressions of burns or burn wounds. You have the zone of coagulation. The zone of coagulation is a central area of the skin which has the most damage, which will have no blood flow in that area. The zone of stasis is peripheral and it is around the zone of coagulation. There is still some amount of blood flow occurring in that area, but it's not sufficient. The zone of hyperemia is the area that is least affected by the thermal injury, and that's the area that has the best blood flow. If the patient doesn't get proper treatment or in a timely manner, the zone of coagulation will start to expand. Now, burn depth. The greater the heat energy, the deeper the wound. Depth classifies the severity of a burn. So with burns, you think about the zones of damage, you think about how deep it goes into the skin and the body surface area that's affected. So depth classifies the severity of burns. Superficial burns, first degree. Partial thickness burns, second degree. Full thickness burns is third degree. The depth of a particular burn cannot be accurately estimated. And there are your examples. Now, in the pre-hospital setting, we only focus on partial thickness and full thickness burns. So those are the burns that we count in the field or pay attention to. Burn severity. 5 factors to determine the severity of a burn. What is the depth of the burn? What is the extent of the burn? That's the body surface area. Are any critical areas involved? Does the patient have any pre-existing medical conditions or other injuries that could be complicated by the burn injury? Is the patient very young? Right? Is the patient younger than 5 years? Or is the patient very old, older than 55 years of age? Burn extent, the rule of 9. It is based on dividing the body into 11 sections, each representing approximately 9% of the total body surface area. The rule of palms uses the size of the patient's palm to represent approximately 1% of the patient's total body surface area. And it is used when the body surface area that is burnt is less than 10% or it is irregular in its pattern. Can barely see the numbers on this chart, but pay attention to what is the same for your infant, child, and adult, and pay attention to what is different. Because when you get these type of questions in exams, you have to be exact with your values, and you have to be exact with in terms of the understanding what exactly is the question asking, and they tend to be very specific questions. Now, the body surface area is very important because a patient that has a severe burn where a large body surface area is affected, they are going to need a lot of fluid within a 24-hour period. And the fluid resuscitation for these patients need to be started within 2 hours. And the fluid that is going to be given is based on their body weight. A very popular formula that is used is the Parkland formula. And we will go into that more when we start to do drug calculation, right? So we're gonna go more into that down the line, but they're gonna need a lot of fluid if they have severe burns. Now, assessment of burns. Complete assessment necessary to determine if there is any more serious injuries. Classify the burn to determine its severity. Conduct a scene size of determine the type of burn that has been sustained and the MOI. Assess the scene for any environmental hazards. Consider the potential for spinal injuries, inhalation injuries, and other injuries. Primary survey includes a rapid full body scan of the patient. Stridor means the patient's airway is swollen and they're at significant risk for airway compromise. Be suspicious of clues. that may indicate abuse. Check for responsiveness using AVPU scale. Look for signs of airway involvement. Quickly assess the pulse rate and quality. Inspect, palpate the chest wall for decap BTLS. And remember that if you suspect airway burns is present, these patients will benefit from humidified oxygen. So humidified oxygen will be beneficial to these patients, and you need to call for ALS quick as soon as you recognize that they might have airway issues. Don't wait on ALS to arrive on location. They may have to meet you at a point, or you may have to just move to the hospital, right? So don't delay transport of a critical patient because you're waiting on ALS to paramedics to arrive on location because you are ALS, right? History taking. Investigate the chief complaint or history of the present illness. Typical signs of a burn are redness, swelling, blisters, or charring. Symptoms include pain or burning at the injury site. Obtain a sample history from your patient. Ask necessary questions. In your secondary assessment, conduct a more detailed physical examination. Quickly assess the patient for decap BTLS. Use the rule of 9 to make a rough estimate. Determine the classification burns during the assessment. Look for soot around the mouth and nose and singed nasal hairs. Listen to breath sounds with a stethoscope, very important. Assess the patient's neurologic system to formulate baseline data. Perform a detailed full body exam to assess the musculoskeletal system. Obtain an early set of vital signs. Use your monitoring devices to quantify oxygenation and circulatory status. So pulse oximetry, end-tidal CO2 preferably, waveform capnography, get your patient on a cardiac monitor, obtain a 12-lead ECG if you think it's necessary, establish IV access, give fluids based on the Parkland formula. Reassessment. Repeat primary survey and reassess the patient's vital signs. Reevaluate interventions and treatment. Provide hospital personnel with a description of how the burn occurred. If special areas are involved, they should be specifically mentioned and documented. Emergency medical care of burns. While assessing a burn patient, check for traumatic injuries or other medical condition. The goals are to stop the burning process. We will assess and treat breathing complications. We are going to support their circulatory system, and we will provide prompt or rapid transport. If the patient has signs of hypoperfusion, treat aggressively for shock. Remember what I said previously. If they have a large total body surface area burnt, they're going to need a lot of fluid because of the shifting of fluid that is occurring. Aggressive fluid resuscitation and general wound care may increase chances of survival. During lengthy transport times, medical control may order the administration of fluids. For thermal burns, a flame burn is often a deep burn. Hot liquids produce scald injuries. They can have contact burn. Steam burn can produce a topical scald burn. Flash burn is produced by an explosion, occurs when the patient is lighting charcoal that has been soaked in lighter fluid. Lightning strikes can also cause a flash burn. Inhalation burns. Most deaths from fires are caused from inhalation or of toxic gases, upper airway compromise, or pulmonary injury. Infection prevention is important in patients with burns. So again, when a burn patient dies quickly, it's because of airway compromise. When they die later on, it's because of sepsis, infection, or fluid deficit. Can occur when the burning takes place in an enclosed space without ventilation. So inhalation burns. All right. Carbon monoxide intoxication may cause permanent damage to organs, including the brain. Be suspicious of pulse oximeter readings when you are dealing with a patient who is suspected to have carbon monoxide poisoning. Hydrogen cyanide poisoning involves the central nervous system, respiratory, and cardiovascular system. Chemical burns can occur whenever a toxic substance contacts the body. Eyes are particularly vulnerable. Now, with your thermal burn, you don't need to run water in the area for a very long time. Usually, after running water on a thermal burn area for 4 minutes, that will cool the burning process. If clothing is sticking to the skin, you have to cut around the area that is sticking to the skin. And if they have burns to the fingers and toes, you have to separate them with gauze. For chemical burns, if we're gonna flush, it's usually 15 to 20 minutes. Severity of a chemical burn is related to the pH level and concentration of the agent, the length of time the patient was exposed, the volume and physical form of the agent. Treatment of chemical burns can be specific to the chemical agent, so it can be a specific type of treatment. Stop the burning process, remove any chemical from the patient. So if it's a dry chemical, brush the dry chemical off, cut off the clothing, and then irrigate. Special management techniques. So for dry lime, flush with copious amounts of water with a garden hose or shower. For sodium metals, cover it with oil. For hydrofluoric acid, calcium gluconate gel is the preferred treatment. For gasoline or diesel fuel, most hydrocarbons are more effectively removed with soap solution. For hot tar, immerse affected area in cold water. So this is a very important slide. It shows specific managements for different chemicals that are common. If the patient's eye has been burned, hold the eyelid open while flooding the eye with a gentle stream of water. Electrical burns may be the result of contact with high or low voltage electricity, result in 2 burn injuries, an entrance wound and an exit wound. And depending on the type of current, it can cause fractures, it can cause cardiac abnormalities. Patient goes into cardiac arrest. Dangers associated with electrical burns. There may be a large amount of deep tissue injury. The patient may go into cardiac or respiratory arrest from electric shock. Look for signs of hypoperfusion and assess the heart rate. For radiation burn, determine whether ongoing exposure exists. I have 3 types of radiation: alpha, beta, and gamma that you need to be familiar with. Gamma would be the most serious. basic exposure pathways, inhalation, ingestion, and direct exposure. And a patient that is exposed to radiation, the sooner the patient vomits, the more likely that patient will die. So if they vomit early, they're gonna die, right? They're not gonna survive. And our final slide is radiation sickness can cause premature aging or even death. Radiation burns require special rescue techniques that are beyond your scope of practice as an AEMT. If not properly trained, maintain a safe distance and wait for hazmat team to decontaminate the patient before initiating care. Establish IV access and give fluid based on the patient presentation. That would bring us to the end of this chapter.